let's get going. Let's kick things off. We're going to start with a welcome from the Chief Medical Officer of Sequoia Hospital, Dr. Dieter Bruno.
Hi, I'm Dr. Dieter Bruno, Chief Medical Officer of Sequoia Hospital in Redwood City, and I'd like to give you a warm virtual welcome. Sequoia Hospital is a community hospital, and it's considered one of the crown jewels of Redwood City. Sequoia Hospital was started in 1950, and it has a long history. In fact, this year we're reaching our 70th anniversary of Sequoia being in the community. One of the things that we appreciate about a community hospital is it gives us the opportunity to have a number of different service lines that take care of patients of not only our community, but surrounding communities. We have a lot of strong individual departments, such as our cardiovascular, medical, and surgical departments, our surgical service lines, our OB service lines, our general surgery lines, and we have a number of interesting facets to technology that we use. We're most excited, however, about our opportunity to interface with the community to teach students, whether or not it's nursing students or physical therapy students. Many times we have people who are in medical school and they come and they learn and shadow and get opportunities to see really what we do and what we do well. I'd like to specifically highlight one of our service lines of which we are extremely proud, and that's our Heart and Vascular Institute. Our Heart and Vascular Institute is comprised of both cardiothoracic surgeons as well as a number of cardiologists, and we have a long history of being able to deliver fantastic care to patients from all over the state of California. We have great leadership in our cardiology department by Dr. Gregory Engel, who you'll be able to spend some time with during this virtual tour. And I'm sure that he will give you a wonderful opportunity to see our facilities and a number of the different ways that our service lines not only engage physicians and nurses, but also a number of the other workers that we need in order to get our jobs done. At Sequoia, we consider ourselves a family. And as a family, we value every member of the family. And we have a wonderful environmental services department that allows us to keep this place clean and functioning well. We have great facilities management that keeps this place spick and span and all of the equipment running. We have something called Biomed that makes sure that all the equipment that we use are up to date. And the number of different contributions from many different areas is fantastic and phenomenal. It's our hope that you realize that every area that touches healthcare is important to us, and it is really important for us to invest the resources into making sure that all of these different areas and service lines do well, and that we continually find new sources of students and education so that we can keep this place functioning as a high reliability organization. And one of our mantras is to keep me safe. Everything that we do is really centered around the patient. And that's something that we always like to highlight, because if we can't take care of patients well, then we're not doing our job. So sit back, relax, and enjoy our virtual tour. And we look forward to showing you everything that Sequoia is made of. Thank you.
Hi, my name is Greg Engel. I'm the chief of the cardiovascular department here at Sequoia Hospital, and I'm excited to join you today to talk about cardiac procedures and give you a tour of our cath lab that I'm standing here in front of. In the cath lab is where we perform most of the procedures on heart patients. I'm what's called a cardiac electrophysiologist. I focus on the electrical system of the heart, and the procedures I do are related to electrical problems, and we'll talk about some of those. Some of my colleagues who work here are called interventional cardiologists. We refer to them as the plumbers. They open up the blockages while I'm the electrician for the heart. We're going to take a tour. We're going to talk about some procedures. Come join me. The cardiac cath lab at Sequoia consists of 6 rooms, which are on either side of me here, that allow us to do a number of different procedures. As I mentioned before, we have electrophysiologists and interventional cardiologists doing procedures. In addition, we have other specialties who work here. We have vascular surgeons, interventional radiologists. We sometimes have our cardiac surgeons in here assisting with procedures. This allows us to do a broad variety of things. We're going to talk about a few of those procedures right now. I'm standing outside of one of our cath labs that's focused on arrhythmias. I'm going to take my mask off since we're filming after hours and no one's around. Arrhythmias are abnormal heart rhythms. There's several different kinds. Most of them are when the heart goes too fast. The most common arrhythmia that we treat is called atrial fibrillation. It's actually the most common serious arrhythmia in the world. Atrial fibrillation is when the upper chambers of the heart are beating very fast and irregular. Normally, your heart has a sinus rhythm. The beat starts at the top, goes down through to the bottom in a very regular fashion. In atrial fibrillation, the atria, the upper chambers, and you have two upper chambers, usually coming from the left atrium, starts to beat very rapidly and very irregularly. It can cause your pulse to go fast, you can get lightheaded, dizzy, short of breath, and there's also some serious consequences to atrial fibrillation. Because of that rapid beating, blood can pool and people can have strokes. On the upper part of this image, you can see normal sinus rhythm. That's the regular rhythm of your heart. It's very regular. There's a small bump, that's the upper chamber contracting. The large deflection is from the lower chamber, and it's a very even, steady pattern. On the bottom, you can see atrial fibrillation. That irregular, chaotic, up and down signal across the tracing shows the chaotic beating of the upper chamber. And the tall deflections are the lower chamber, but there's no rhyme or reason, very irregular pattern. One of the ways we treat it is with an ablation procedure. An ablation is essentially to go in and burn or cauterize tissue to stop the arrhythmia. Let's go inside and I'll show you how we do it. Arrhythmias such as atrial fibrillation and other arrhythmias can be treated in multiple ways. We often use medications for these patients, and sometimes medications are enough. But some patients need to come here for procedures like an ablation. This is one of the rooms where we perform the ablation. Obviously, we don't have a real patient here. We have a fake patient for you today, but this is where the patient would be. This is the fluoroscopy equipment or the X-ray equipment that allows us to see inside the body. Right here is an image of what the X-ray looks like. Here's an X-ray of someone's heart. You can already see one of our catheters. It's a plastic tube that we put inside the heart. It has little metal electrodes on it that allow us to measure the electrical activity and essentially see the electrical signal inside the heart. And if you look up here, that's actually an image of what an electrical signal from inside the patient looks like. Once we get our catheters inside the body, we're able to manipulate them and move them around. And over here, you can see an image of what it looks like in 3 dimensions inside the heart. That's an image of just the left atrium of the heart. That's where we work on the heart for atrial fibrillation. And I'm going to talk in a little more detail about how we do that. This is one of the catheters we use inside the body. We insert the catheter into a small incision in the leg around the groin area where there's a large vein where we can go pretty much straight up to the heart. Once the catheter is in that vein, we can maneuver it inside the heart and get it to exactly where we need it to go. There's a lot of range of motion. This is a circular catheter that we use to map. And if you see carefully in there, there's little metal electrodes on that catheter. There's actually 10 pairs of them that allow us to measure the electrical signal. Now I'm going to talk about one of the coolest pieces of technology that we use, a 3-dimensional mapping system. So once we get the catheters that I showed you up into the body, we go up through the leg, up into the heart. This technology allows us to see the heart in 3 dimensions in real time. What you're looking at is an image from a patient this week. This is just one chamber of the heart, the left atrium. The 4 tubes you see are the pulmonary veins. Those are draining blood into the heart from the lungs. And the catheter you see is very similar to the circular catheter we looked at. This is a spatula-shaped catheter, and we're rubbing it along the inner surface of the heart to actually develop this 3D picture and measure the electrical activity. And this is in real time. That's as you move the catheter inside the heart, you see it move around. And this allows us to map out and plan our procedure. We're standing in the back of the ablation room we were just talking in. In addition to the ablation procedure itself, there's a lot that goes into this, a lot of technologies we're using, a lot of people involved. We do EKGs on patients, we hook up electrodes to see the electrical signal of the heart. We showed you in the ablation the inside signal. We need to see the signal from the outside of the heart on a surface electrocardiogram, just like you get one in the office. We also do echocardiograms to show images of the heart. We'll do that before in the office, during the procedure, and sometimes after the procedure to look at the structure of the heart. Here's an echo machine right here, one of the pieces of technology we use to get those images of the heart and make sure the heart's moving normally and the valves are functioning. These are all important pieces of getting a patient ready and keeping a patient safe during our procedure. When we think of heart rhythm, we're talking about how the heart beats. We use certain terms. When the heart's too slow, we call it bradycardia, slow heart rate. When the heart's too fast, we call it tachycardia, fast heart rate. Sometimes these are quite abnormal and we have to treat them, and we're going to talk about some of those ways. But why don't we do a little interactive project together? So we're going to have everyone check their pulse. Okay, there's a couple ways you can check your pulse. Most people, if you hold your wrist, this side of the wrist is we call the ulnar side. This is the radial side. You have a radial artery right here below the thumb. And if you push down right here, in most people you can feel a pulse there. That's one way of getting your pulse. In some people you can feel a pulse right on your forehead. A little pulse that's right near the surface. You can also check the carotid artery in the neck. We're usually a little cautious, don't push too hard on your neck. But let's all check our pulse together. So we're going to give you 15 seconds on the clock. You count each beat during that period of time and multiply it times 4. So everyone go ahead and find your pulse now. On the wrist, under the thumb is usually the easiest spot. We'll time all of us for 15 seconds. Everybody ready? Ready, set, go. Don't worry if you couldn't find your pulse. You can always check it later, and I promise all of you have a pulse. Now take the number of beats you counted in 15 seconds and multiply it times 4 to get your beats per minute. For example, if you measured 15 beats in 15 seconds, that's going to be 60 beats a minute. The official normal is between 60 and 80, but don't worry if you're below or above that. Below 60, especially if you're athletic, is going to be quite normal. People are very commonly, when they're young, in the 50s, occasionally even dropping to 40s, especially at rest, and that can be quite normal. Above 80 can also be normal at times. If you're way below that, especially if you have symptoms, or way above it, sometimes you need treatment. For those patients who have low heart rates, when it gets too low, sometimes they can get lightheaded, they can get short of breath, they can have trouble with activity, and there's not much in the way of medications that will often fix that. So what do we need to do? We put in a pacemaker. A pacemaker is a device that speeds up the heart rate. They're very smart devices these days. They watch each beat, and they trigger when your heart needs to beat, an as-needed or on-demand pacemaker. The pacemaker is a small metal box. It goes in the chest area, in the upper left chest usually, and there are wires or leads that go into the heart. Most pacemakers are dual chamber, where one lead goes to the upper chamber, the atrium, and the other lead goes to the lower chamber, the ventricle, and they coordinate the heartbeat. I can show you an example here of what a pacemaker looks like. This is a model, of a dual chamber pacemaker. The leads go in the top, and this is the part that sits up in the chest. For some patients whose hearts go too fast, who have dangerous arrhythmias, some people who've had prior heart attacks or have a weakened heart, their hearts can race so fast that the heart essentially stops beating. And this arrhythmia is called ventricular tachycardia or ventricular fibrillation. It can be life-threatening. For those patients, we put a device in very similar to a pacemaker, but we call that a defibrillator. All defibrillators are capable of being pacemakers, but the defibrillator function allows it to deliver a large electric shock to stop those dangerous arrhythmias. Defibrillators, very similar to pacemakers, have leads that go in the heart, and our boxes are just a little bigger and a little thicker than a pacemaker. But they're put in very much the same way, and they provide that extra protection like a built-in emergency room in your chest. When most people think about heart disease, they think about blockage of the arteries. Turns out we have arteries that run on the surface of our heart that supply the blood to the heart muscle itself. When those arteries get blocked, usually by plaque and cholesterol and buildup of atherosclerosis, which can get progressively worse, and even you can get sudden rupturing of the plaque that blocks an artery. When an artery is blocked, we call it a heart attack or a myocardial infarction, nicknamed MI. What does that mean? Myocardial refers to heart muscle. Infarction means death of tissue. When an artery is completely blocked, the muscle behind it dies, and that causes a heart attack. If the artery is narrowed and there's not enough blood flow, we call that ischemia. That's a lack of blood flow. That can cause chest pain. And the fancy word we use for chest pain related to the heart is angina. Our primary goal is to prevent this from happening. There's a lot of things we can do. There's medications we can give people at risk. We can work on diet and lowering cholesterol, sometimes with medications if diet doesn't work. We can talk to people about losing weight. We can avoid smoking. These are some of the major risk factors in society that can help prevent these things from happening. When we're not able to prevent them, we sometimes end up in a room like this. This is one of our cardiac cath labs where we do procedures for blocked arteries. We call the procedure a cardiac catheterization, putting a catheter in the heart, or angiography, looking at the blood vessels. Catheter goes up through the leg, similar to most of the procedures we do here in the cath lab. And we go into the opening of those coronary arteries and we inject what's called contrast material. Under an X-ray camera, which you can see here behind me, we use the X-ray images to see that contrast material. And that just allows us to see the inside of the arteries. If there's a blockage, you'll see a narrowing of that artery. Once we see the blockage, we can go in and treat it. The way we treat it is essentially to open up that blockage. We can do what's called angioplasty, and that's when we put a balloon in to open up the blockage. And that these days is almost always incorporating a stent, which is essentially a metal scaffolding that goes up and keeps that blockage from reaccumulating and compressing back down. So you essentially do the angioplasty, which is the balloon, and that expands the stent to open up the blockage. And that's the primary way both acute MIs, acute heart attacks, are treated, by opening up a complete blockage, and also people who are more stable, who are having anginal chest pain. We can go in and put a stent in and open up their blockage and improve their symptoms. To take care of patients, it takes a team. It frankly takes a village. There's a lot of members of the healthcare team, and everyone plays an important role. We're excited today that you're going to get to meet some of those members of the team. Today you're going to meet a medical assistant, an echo technician, an administrative assistant, and a finance manager. Let's go meet them.
Hi everyone, my name is Maria. I'm the administrative assistant at Sequoia Hospital Health and Wellness Center. I started working at Sequoia Hospital before I graduated high school back in 2015. I started working there as a student clerk before I got promoted to administrative assistant. I decided to work in this department because before I graduated high school, I actually was interested in going into the medical field. I wanted to go into college and get my nursing degree and just, be a nurse at a hospital. I wasn't really clear what I wanted to go into. Then when I started at Sequoia Hospital, after taking a few classes at Kenyatta College for nursing, I decided that wasn't the major I wanted to go into. So I ended up switching my major and trying out the medical assistant program at Kenyatta. And when I started taking the medical terminology class at Kenyatta, I decided that wasn't it either. So I decided to switch my major. Right now, I'm a month away from receiving my associate's degree in administration of justice from College of San Mateo. And I'm the only one right now that is still in school and close to graduating. My parents, they migrated from Mexico. So I was actually born in Mexico. And I moved here when I was 9 years old. Still, my parents don't have the experience of going into a job interview or building a resume or anything like that. So I had to, be independent and kind of learn all of those things just on my own. And with being with Sequoia Hospital, I've actually had a lot of help from them. I learned to see them more than coworkers, as a family, because now that I'm close to graduating, they've kind of been the ones that have been putting me, helping me along the way with school, with work, with being flexible with my classes and my school schedule. They've always told me, school comes first. If there's anything we can do to help you, we're here for you. And they've been, that support that I couldn't have at home. I actually found it at work with them. So throughout this 5 years, if I was to be asked what is one thing that I like most about my job, there's definitely not one thing at all. I was very blessed, I could say, to be able to do is to be here at the hospital and help our CSU unit during the pandemic while the hospital was shut down. I was able to come up here and to work at that unit and be really close to the nurses and doctors here. So it's one thing that I never thought I would be able to do because I don't have the medical background to even, be working at a hospital, you would say, at the hospital building. But with my administrative assistant skills, I was able to come up here and also help the nurses and the patients here with answering the phone and transferring patients' family members to their rooms because, as you know, a lot of hospitals aren't taking in visitors. So I was able to transfer those family members to the patient to communicate them with the nurses and the staff whenever they had questions. I was able to help the nurses with, whoever needed help in the rooms to tell them, a room 103 needs your assistance or somebody needs help. I was able to be here and help them and also see how close the pandemic hit our staff here at the hospital. So it was really an eye-opener for me, I would say, and it's something that, even though right now I'm not graduating in anything that has to do with healthcare, definitely helping during the pandemic year really opened my eyes to know that I still want to do something in healthcare.
Hello, my name is Christopher Short. I'm the lead cardiac sonographer, or Echo Tech, for Silicon Valley Cardiology. I'm responsible for providing accurate ultrasound images for the doctors and excellent patient care. I come from a single mother household with lots of challenges. We lived in motels, hotels, homeless shelters, and I never wanted to experience that or let my children experience any kind of poverty like that, so I was very self-driven. I worked at Best Buy for 5 years after high school, and I went to San Francisco State University and City College of San Francisco to study cardiovascular technology at the same time I was working with Best Buy. Learned lots of skills working at Best Buy, communication skills, some business acumen, sense of integrity, and just the overall desire to help people understand their technology needs. I would like to take the time to ask and answer a few questions. First question, what or who inspired or motivated me to get into this career path? I would say it was Dr. Stephen DeGallen. I was able to make the journey into cardiovascular technology because of him. My wife used to work as a chart preparer for him, and I would come down to the office on lunch breaks, talk with him and visit with him and hang time with my wife as well. He knew that I was into technology. He also knew that I helped take care of my grandmother who was paralyzed. So he did a wonderful job of fusing both patient care and technology for me into this wonderful career path called cardiovascular technology. Second question, what qualities or personality traits do you think are most important or helpful in your role? Personally, I believe that compassion, patience, sense of humor, self-drive, and pride are all very important for a cardiac sonographer. Compassion. We need to remember that people are here looking for answers for some kind of sensation that they're feeling that's new to them, or they're recovering from some kind of traumatic experience. We need to understand that and be there to help guide them through this time. Patience. Again, people may be dealing with some difficult things, rehabilitating from traumatic procedures, dealing with the unknown, and they're scared and nervous. Sense of humor goes back to dealing with patients. Remember that we're dealing with people and not just another test at 10 o'clock in the morning. Get to know them, make them feel human, laugh, talk, joke. Again, this is not going to be the last time we see this patient. Develop that relationship and they'll be glad to come back and see you. Just a few more moments here. I have our ultrasound technology up. It's a picture of a heart there. We use a transducer with ultrasound jelly that we apply to the chest and take some live videos and still frames for the doctor to review. Thank you for your time.
Hi, my name is Mercedes Espinosa. I am the manager of finance at Sequoia Hospital. My responsibilities include development and implementation of the operating budget. I assist in month-end financial close process. I also assist the preparation of monthly flash report for our CFO. I work with daily productivity for our departments. My background and education is as follows. I was born in Aguililla, Michoacan, Mexico, and I lived there until I was 12 years old. I started school when I was 6 years old in Mexico and loved learning and found that I always wanted to be the best in my class. Not always achievable, but I really tried. My parents moved the family to the United States when I was 12 years old. At that time, I only had 3 brothers and a little sister. We moved to Redwood City, and I started elementary school for the last 2 months of the school year. I then moved myself, and I enrolled myself to Kennedy Junior High because I wasn't enrolled. I just showed up, and they had to enroll me. I graduated there 2 years later, and then I went to Sequoia High School for 4 years. At that time, I knew that my parents couldn't afford to send me to the university, so I enrolled at Cañada College for 2 years. I then transferred to San Jose State University, and I was able to obtain a Pell grant and a Cal grant, which helped with the cost of the university. I, however, I only studied for 2 semesters at the university and dropped out because I felt like I needed work experience. At that time, I was able to get a part-time job at Sequoia Hospital in the accounting department. And it was supposed to be 4 hours a day for only 4 months. And I stayed there 35 years already. I love to work with numbers. But I got married and had 2 children, but I never gave up on finishing my degree. Thus, it was 12 years later that I enrolled at the University of Phoenix, and I was able to obtain my bachelor's in business administration. It took me close to 3 years of going to night school, as I also held my full-time job in the daytime. I will answer 2 questions. What do I like most about my work? I love working with numbers and assistant managers to understand the various financial reports that will help them make better decisions. I feel that my work makes a difference and that I'm helping others. The other question is, what and who inspired me to motivate me to pursue this career? I would have to say it was my mother. My mother is the smartest woman I know. She didn't go to school because her father died when she was a little girl, and her mother put her to work instead of sending her to school. However, she did learn the alphabet as a little girl and taught herself to read and write as an adult. She was not able to help me with my homework, but she always encouraged me to do it myself. I learned budgeting because of her. Not that she was trying to teach me, I think, directly, but when I was 7 years old, my mom gave me 100 pesos and a list of items that I needed to get from the supermarket. I had to memorize the list because she really didn't know how to write it very well. So I found that I was really good at doing that kind of job. I was able to buy all the items that she asked me for and was able to also fit in my budget some treats for myself and for my siblings. So I have other people that I really admired throughout my career, but at the top of the list is my mom. Thank you so much.
Hi, my name's Yvette. I'm a medical assistant at a cardiology department. Some of my daily goals and tasks include doing EKGs on patients, putting heart monitors on patients to check what their heart rhythm is. I grew up in East Palo Alto. I went to a public charter school in Redwood City called Everest. After I went to Everest, I went to Sonoma State for about 1.5 years because our goal was to go to college at that school. So they really emphasized that. So I ended up going to Sonoma State. I ended up coming back after 1.5 years. It just wasn't a good fit. It didn't end up working out for me. I ended up not knowing really what I wanted to do, but I felt this kind of sense of urgency to be productive. So I ended up working 4 jobs. I ended up working at a after-school program, at a hookah night lounge. I ended up working at a real estate agency, and also serving lunch for the Palo Alto School District. So I did a bunch of different things. My goal was kind of to get a different taste for different things, to figure out what I liked. My friend had told me about a job train and a medical assistant program there. He recommended me to look into it. I did, and I started the program because it seemed like something I could do. I ended up falling in love with it, and it was really a really great experience. The application did take me really long to complete, but it was definitely worth it for sure. I'm very content with where I am. I'll be answering a few questions and answers. So what qualities or personality traits do you think are the most important or helpful in your role? I think there's a few important qualities that are really important as being a medical assistant. The first one is taking initiative. We want somebody who is actively looking for things to do. If you have a set amount of tasks you have to complete, kind of planning it out and mapping it out yourself is really a good quality that we look for. Also, communicating effectively and clearly is really important, especially in the medical field. You just want to make sure that nothing gets misconstrued or kind of confusing. And then we also want someone who's a team player, somebody who's working with the group to achieve the same goal, which is to give patients the best quality care. The last thing I would say that is really important is being curious, asking a lot of questions even though you may have asked the question before. Taking notes is really important as well, just so that way you have that information and you can just look back and kind of study it, and that way you're prepared. The next question is, what recommendations do you have for high school students who are interested in this role or who are interested in getting into healthcare? If you're interested in becoming a medical assistant, I recommend kind of looking up the job description and kind of getting an idea of what it's like. Even though a medical assistant, you can work in a variety of departments. Depending on which department you're in, kind of just depends on what you'll be doing. So say, for example, in cardiology, I do EKGs, place heart monitors, and things like that. But there's other departments where you would be doing different things like urinalysis, blood draws. It just depends. So doing research would be a really good thing to do, as well as getting your foot into a medical facility. Say, for example, by volunteering. You can volunteer at Sequoia or Kaiser, and they have applications you can fill out to help volunteer. So one more thing, if you are interested in becoming a medical assistant, one of my daily tasks is doing EKGs on patients. What we do is we'll attach these electrodes to the patient. It'll mostly go on the abdomen area. One will go on each arm and one on each leg. After we do that, we'll go ahead and get the patient connected to the machine, and then it'll show us on the machine what their heart rhythm is doing in that moment, and what heart rhythm they're having in that moment. But it's solely based on the electrical activity of the heart. Bye, thank you.
Hi, everyone. Welcome back. Hope you enjoyed the tour of the Cath Lab and our panelists' presentations and stories today. We would now like to switch gears and move over to our live Q&A. We are going to be moderated by Dr. Greg Engel, and he will be joined by our panelists, Chris, Yvette, I think we're looking for Maria, and hopefully Mercedes too. Very happy that you guys submitted so many fantastic questions. We're going to ask our panelists to unmute themselves and turn on their videos. Hopefully Mercedes can join us too, but we can kick things off with this group here. So let me pass the baton.
Well, welcome again, everyone. Thank you. Got the opportunity to have everyone here who you saw in the video.
Nice meeting everybody live on Zoom. And I think we've got all of our panelists here. And let's have everybody come off mute. We received a large number of questions and some terrific questions. I've had a chance to go through the questions. We're not going to obviously get to every question. I think we received about 100 different questions, some for me, some for each of our panelists. So I'm going to go back and forth, ask each of our panelists some questions and answer some of the questions that came from me. If anyone has new questions that have come up after watching the videos, you can enter them in the chat. If you want to send it privately to Dee Dee, who's the host, you can do that as well. She'll be coordinating any questions that come in while we're talking. So here we go. I'm going to throw out the first question to Yvette. Yvette, how much training is required to be a medical assistant?
So for medical assisting, to become a medical assistant, it kind of varies depending on the program. So I went through a vocational program, and that was a lot shorter. So I went for about 9 months or so. There's also other vocational programs like Gurnick or Unitech that have medical assisting, and those also range anywhere from a year to 2 years. It kind of just depends on where you go. But it could range anywhere from 9 months to 2 years.
Great.
To get certified.
Get certified. Thank you. All right, we're going to keep jumping around. Mercedes, here's a question. What does your daily routine look like? And how does your work schedule differ from other people in the medical field?
So my daily routine, I usually start work between 8 and 8:30 in the morning, unless there's some meeting that I have to attend earlier. And I usually try to leave by 5. I think the difference is that I don't see patients. I work with financial reports, and I work with management, not necessarily with the patients. I think that's the difference.
Great, thank you. And I'll preface, we're obviously not going to say who the questions came from, but a ton of questions from all the kids in both schools. I'm going to ask Maria the next question. Maria, this is a two-parter. What's the favorite part of your job? And what part of your job might you want to change?
I love everything I do. From, prior to COVID, I did used to schedule or outpatient lactation appointments for new moms. So I used to love being on the phone with them and actually scheduling those appointments with them, because you get that interaction prior to them coming in here. So you're that first person of contact that they have. If there was one thing that I could change, right now I only work part-time, so definitely go a full-time job. But I love everything that I've been doing here from, if anything, I also do a lot of our programs for classes and events. So that's something that I also enjoy doing a lot.
Great, terrific. All right, Chris, a couple different people asked these questions along the lines of, what classes in college do you need to take to become an echo technician, and how long does it take to go through the training to become an echo technician?
Yes, the prerequisites are anatomy, physiology, your basic college level English, some college level math. Then you enter into a specialized program for 2 to 3, maybe even 4 years, depending on which program that you apply to. But it ranges from about 2 to 4 years, just depending on the program.
Excellent. And then a follow-up, one of the students asked, how many colleges offer these programs? Is it only certain colleges, or does everyone offer this?
It is very limited here in California. I know of about 3 city college and community colleges that specifically focus on adult echo. There are more colleges that focus on general ultrasound, being abdomen or legs or arms or brains, but about 3 to 4 for adult echoes or hearts.
Okay, great. Okay, let's go back. Mercedes, I'm going to come back to you. I got a note, a couple people might not have been able to hear you clearly. Make sure you're aiming towards the mic. So I've got a two-parter for you. So part one, do you feel that with your job, you're able to cover expenses and live in the Bay Area on your salary? That's part one. Part two is also financial. Do you have any suggestions on the ways to pay for college? You mentioned in your talk some grants and other things that you're able to get. So please tell us about that.
So I have been living here in the Bay Area for a long time. So I think I make a really good salary, but also because I bought my house like 30 years ago, I think that's one of the highest expense that anybody has. So yes, I can live on my salary. But if you were somebody who is just getting a job, I think the salary that finance managers make is really good. So, I mean, the cost of living is really high in the Bay Area and it still be a challenge, but you can achieve it. And then how can you cover the cost of college? I went to community college in order to save money. But what I found was there's a lot of scholarships out there that you can apply. And one of the sources that you can probably check with is your high school counselors, because they have, I think, a lot of resources. They can tell you which scholarships are available and when you can apply for them. When I graduated, which was a very long time ago, I got several scholarships. I got one from the Rotary Club, and I know those are still around. I got one from a church, and then I got another one from a club it was a student club at the high school. I don't know if it's still around. It was in Sequoia High School. It was called MISO, Mexican American Club. And then I also applied for a grant from the CalPA and the Cal and the Pal grants. And I got those, and that really helped. As I said on my interview, I didn't go for the straight 4-year college. I kind of stopped and then I restarted again 12 years later. At that time, I had to actually get a student loan. So I always say, try the scholarships first, the grants, and then as a last resort, get a student loan. But don't give up because of money. You're investing in yourself. So go for it.
That's great advice. I love that. Thank you. I'm going to go back to Yvette. Here's a good question that came in. Did you study to become a medical assistant as your final goal? Or is this a job where you're trying to gain experience to move on to do something else in the healthcare field?
No, my end goal isn't being a medical assistant. I've had like a lot of variety of interests working here, just being exposed to different things and people in my department doing different things. So I don't see this being the last stop for me personally. I've been interested in getting certified as an EKG technician. My colleague also let me know about becoming an echo tech as well, and a nuke training program as well. So I think it's just my goal right now is just saving up enough money so that way I can go to school and focus on school full time. That way I can, do something a little different, but kind of stick in the same kind of department for sure. So, yeah.
Great, thank you. Chris, I'm going to come back to you. So one person, that's a great question. What is the part of your job you enjoy the most?
The part I enjoy the most is definitely the technology, getting to see hearts moving in live motion and figuring out and seeing what's causing people discomfort is probably the best. There's nothing like it. And then being able to find that problem and provide it to the doctor so they have a plan of action to help correct that and make people feel better in the end. That's the best part.
Terrific. All right, I'm going to go back to Maria. Maria, there's a question about what does a medical administrative assistant do? Now, obviously, you told us in your talk that during COVID, you had some other roles. What would be the standard job of an administrative assistant?
Do a lot of things. I do from scheduling appointments. Right now here at the Health and Wellness Center, I also do a lot of the scheduling for classes, for prenatal classes. So before they actually, go into the hospital for new parents to deliver their babies, we do take some classes prior to that. So I do the scheduling and the setting up those classes in the back end as well. Helping here my manager with other community work related programs that we do for the community. Right now, I'm also doing COVID testing out in the community. So as an admin, you would think, well, you're only
in one spot doing one thing. But here I've actually had the opportunity to do a lot of different things that aren't just related to computer and emails and phone calls. You would think that that's the primary thing that I would do, but I've been also doing a lot of patient interaction, community interaction, and there's a lot of things that go into being an admin, not just one set of things.
That's great. Well, it sounds like you jump in whenever they need you. That's terrific.
Yes, I do.
All right. Okay, I'm going to jump in and I'm going to answer a few questions that came towards me. And then if anyone has, as I said, questions for any of our other panelists, please put them on Zoom. I am going to come back to our panelists, so be prepared. I'm going to come back to you. So a number of students sent questions, and I'm looking at the question list here, about training and education to become a physician, a cardiologist. So, and career path, number of years, how do you go all the way to cardiology, chief of cardiology? So I'm gonna try to walk you guys through this quickly because I don't want to take a lot of time. It's a lot of years, but 4 years. Yeah, so here we go. 4-year college, post-college, med school is usually 4 years. For my background, to become a cardiologist, you train in internal medicine. So there's a 3-year internal medicine residency. I became chief resident, which is an extra year. So that's 4 years. Then you go cardiology training, which is usually about 3 years. I was also chief fellow. Cardiology, it's called a fellowship. Well, you do that simultaneously. And one of the years is usually some research. Then electrophysiology is another year added on to that. So this is 12 years post-college. So it's a significant amount of time. Now, I will tell you, once you finish med school, you get paid. It's not a high salary, but you get paid. So you can think of it kind of like an apprenticeship at that point. So you got 4 years of medical school, and then it's arguable whether you're in school or in a job. It's kind of a hybrid of the two. As far as beyond that, so I've been at Sequoia for coming up on 15 years. And moving on to sort of a role as chief, I mean, it's a voting process for the physicians, and it's usually somebody who also is involved in the administrative side beyond just patient care. It's not a different patient care responsibility. You have quality responsibilities related to other physicians, but not different patient responsibilities. And someone asked, what did I major in college? Now, I will preface this, you can major in anything in college. I have some friends who were English majors and went into medicine. I was biochemistry major, a little more science related. But as long as you do your pre-med requirements, it doesn't matter what your major is. And someone did say, even before I had listed the number of years, was the outcome worth the time you've spent? And I'd say absolutely. I love what I do. It's extremely rewarding. I have no hesitation to do it over again. Several people asked about stress. Do you get nervous before procedures? Things along those lines. Why would you go into a field if you know it's going to be stressful? So my feeling has always been, if you don't get a little nervous, then you're not respecting enough how serious some of the things we do are. But you control that, and that actually helps you make it safe for patients and keep you cautious. So yes, there's stress involved, but you learn how to adjust that and use it to your benefit. Good. Okay, there's a few more questions about technology. So I'm going to stop there, and I'm going to come back to our panelists. Several questions specific to several of our panelists basically boil down to the same type of question. So I'm going to go through, I think Maria did this one already, which is, a day in the life. So Chris, let's start with you, and just what's a standard day in the life? And then we'll ask Yvette and Mercedes the same question.
Yeah, so the standard day in the life is to first take a look at your schedule, see how many patients are on there, and do a little bit of background research on them, see had they had previous tests to compare your current test to, and what you're expecting to see in that test. After performing the test, you go back and create a skeleton outline of the report for the physician to go back in and finish completing. And we generally do that 6 to 8 patients a day. And it's a pretty full day, but it goes by quick. And again, it's very rewarding being able to help people and see the outcomes that come from your testing and the results after doctors have treated it.
Great. Okay, let's go on to Yvette. Same question, day in the life.
Yeah, so it's kind of similar to what Chris also mentioned. Going through and seeing what their kind of history is, since usually we'll do EKGs. So to see what their kind of heart rhythm usually is, just so that way you're kind of aware that, oh, this isn't something new. This is something that the patient has had for a while, or, oh, wow, this is something different, or the patient just had a procedure and they're back in another rhythm or something like that. So just kind of going through and making sure you're kind of prepared and you kind of have an idea of what to expect. Even sometimes you have an idea of what to expect and it can be completely different, but just going through and taking those steps really makes it a lot easier.
And great, thank you. And Mercedes, I think you probably answered this. Anything you want to add on day in the life?
Well, my day usually starts, I have a routine and it just makes me kind of ease into the day. And so what I do is we call it the daily census report. So we're trying to figure out what our volumes are at the hospital from the previous night. So that's the first thing I do is just do the daily census, see how many patients we have in the house. And then I go on to do other tasks. And every day is a little different because we have different projects going on throughout the year. So sometimes we're doing operating budget. Sometimes right now we're doing what we call the long range financial plan, which is a 5-year plan of what our finances are going to look like. And so sometimes I'm doing service lines analysis. So every day is a little different, except for those first couple of hours that I'm working on routine work.
Terrific, thanks. I'm getting the warning that it's getting to 3:25, and I've got a couple other people we're going to add on to speak. And if we have a minute at the end, I'm going to just do one question that I can't resist not answering. And then maybe at the end, if we have a minute, I'll couple others. Here's a question. I'm going to read this one. Would you say your job is accurately represented in Hollywood, like this TV show Grey's Anatomy? So there's been a lot of medical TV shows, and my number one comment is some of them are more realistic than others, but even when the medical aspects are realistic, the amount of crazy things that happen in a day, they take 1 year and compress it into a 1-hour episode pretty standardly. So that one I couldn't resist answering, but often they're pretty accurate, but you don't see that kind of crazy stuff every day. Okay, I'm gonna turn this back over to Dee Dee, and I'll take a look if there's any other really cool questions we'll answer at the end. Add Dee Dee on here and switch some of our spotlights.
Hey guys, we have come just about to the end of our time together. So I hope that you guys enjoyed it. Thank you so much for joining us. We wanted to wrap up by letting you know that you can reach out to us if you have some follow-up questions or want to reach out to anyone individually. I am just going to show you that we have put together a list of email addresses for the panelists, and everyone has said that they're more than happy to communicate with you guys if you have specific questions for them. I will send these email addresses out to your teachers as well. So don't worry if you don't have a chance to write them down now. In addition, we are going to put a survey, very short survey, and drop it into chat. Should take you no more than a few minutes, but we really, really appreciate the feedback on today's presentation. And one more thing that we are going to be sharing with you is a resource guide that we have put together on entry-level jobs in healthcare beyond the ones that you've heard about today and including the ones you've heard about today. So we have a pretty big collection of these jobs and terrific information about them in terms of free training programs, lots of information and resources about them. So we're trying to help jumpstart the research process for you. And we have a few ideas for enrichment programs in there as well. So that's to come. We'll send it through your teachers. I do just want to call out a huge thank you to Sequoia Hospital, to the whole team there for making this day possible. Thank you all so much. And a special thank you to Marie Violet and Trisha Coffey, who were my partners in crime. Also, thank you to Amy Wender from Wender Weiss Foundation for Children. I wouldn't be here with you today if it wasn't for her. And a big thank you to Kevin Richardson, who is not with us now, but he was our star filmographer who took all the video footage that you guys saw. And I think you would agree he did a great job. Last but certainly not least, I want to thank the schools that are here today. I want to thank Wilcox High School, Julie Bedell and Mike Bunsick. And I want to thank East Palo Alto Academy, Cotran, very much for your partnership and assistance today. I am going to pass the baton now to Mike to say a few words, Mike Bunsick from Wilcox High School, followed by Cotran from East Palo Alto Academy. So thanks very much, everyone.
Well, Dee Dee, I just want to echo that and thank everyone on the panel from the hospital and everyone from both high schools for being involved. What a tremendous production. I'm very impressed, and I think our students are all lucky to have been here, and we'll be sure to follow up with questions and thank everyone again. So that's all I can say, really.
And I feel almost speechless. I just want to thank Dee Dee again for organizing and coordinating such a beautiful experience for our students. I also wanted to thank all the panelists because your stories are so inspiring. And I think that our students can really relate and resonate with different aspects of yourself that you shared here today. So thank you so much for sharing and for giving us this knowledge about jobs that we might not know about. I really appreciate it. And I'm really excited to continue working with you all in the future. Thank you so much.
Awesome. Thank you both. It's been a pleasure. I will say our time is up. It's 3:30. So if anybody needs to drop off, feel free. It's been a wonderful experience being with all of you today. Dr. Engel has offered to stay on for a few minutes longer if anyone has a few extra minutes just to answer a few of the questions he didn't get to on the list, but really the official time is over. So if anybody needs to drop off, we'll just record these for the video if nothing else. So thank you so much and have a wonderful day. And I will actually pass the baton back to Greg to answer a few more questions for anybody who wants to stay on a few more minutes.
Perfect. I can't resist. There's some terrific questions in here. I'm just going to shoot into the chat. There was a really good one in here. Oh yeah, someone asked about volunteering. So I'm not sure what's happened at every hospital. Sequoia made the decision not to add any volunteers during the COVID situation, just because of not exposing anyone else potentially. Some hospitals may still be allowing volunteers at this time. So right now, not new volunteers, but that's a great thought. And volunteer work is a great way to talk about, I was going to talk about that. It's a great way to get into medicine and get to know the field and figure out what you like in the field. And there we go. One of the questions that came to me is, how did I decide to go into medicine? And I'll just add this in a quick summary. My grandfather had a very debilitating disease called ankylosing spondylitis. I started to research it while I was in high school, wrote some papers on it, got actually much more interested in research, decided I would go to medical school, but then go on to research. And as part of preparing for that, I started volunteering. And I did volunteer work at a lot of places, but one of them was in an emergency room transporting specimens, basically running around the hospital with blood and urine samples from place to place. But I got a feel for what was going on. I got to see what was happening. And I realized I loved patient care and I wanted to be directly involved. And I transitioned from doing research to becoming a physician. So volunteer work is terrific. I'm a huge fan. All right, let me jump in here. There's a couple other technical questions. And I'll hit a few of those for those who are left. And obviously, we'll keep it recording. Okay, in my opinion, what is the newest, most fascinating, or most innovative technology that's been used in order to treat certain heart diseases? I would say overall is placing heart valves into people without open heart surgery. The main valve is called TAVR, and it's transcutaneous aortic valve replacement. And the term we use is either percutaneous, which means getting into the body like we described with catheterizations where we go up through the leg. We can actually now go up through the leg, go inside the heart, and when you have a heart valve that needs to be replaced, we can pop open an entire valve, just like a stent, but now it's an entire valve to replace the prior valve. And it's an impressive thing. And instead of patients having open heart surgery with a multi-month recovery in some cases, or at least a week in hospital, you know, a month plus of rehab, patients go home in a day or two. So that's a paradigm shifting, groundbreaking technology. Hit a couple other questions. Are there alternative methods to an angiography, and does the dye have a negative effect on one's health? Yes, nothing is quite as good as angiography as a gold standard, but now we can do CT scans and we get pretty close. So in many cases, we'll do a CT scan and we can see the blood flow in the arteries. It's still not as good as going inside. And if you need a stent, we still have to go inside. And the dye, which we call contrast material, can negatively affect the kidneys, and there can be allergic reactions to it. The contrast material we use today, as opposed to many years ago, those risks are much lower. So allergic reactions are rare, but still occur, and they can be treated. And we do have to be careful with patients with kidney problems. You have to give them a lot of fluids to protect their kidneys. And then a couple people asked, how do you get those catheters where they need to go? So a couple tricks to that. One, when we put the catheters in the body, we use a wire that has a J tip on the end and a very smooth, soft tip. So if it bumps against things, it doesn't do any harm. That's one of the questions, you know, can you harm people doing this? It is possible, but that wire guides ahead of the catheter to make sure we're smooth. We look where we're going on x-rays, and almost all our catheters have some form of bend on the end, and then you can turn to get where you need to go and use the x-ray guidance for your path, or sometimes you inject some of that contrast material if you need to see where you're going. And then why do we go through the groin if it's so far from the heart? In the groin, you're going through the femoral artery or femoral vein, depending on the procedure. And there's some of the larger vessels in the body that are easy to get to, and they're pretty straight shots to the heart. And if there is any bleeding there, it's very easy to control rather than going up closer to the chest. And then someone asked about how long does someone recover before discharge? Actually, you can have, for an angiogram. So you can actually have a stent placed and go home even the same day now, if you're quite stable. Most people will stay one night. Ablations are similar. Some people can go home same day. Some of our more complex ablations, it's one night. But the recovery is pretty quick. You got to take it easy for a week because the catheters went up through the leg and there's a risk of bleeding. So we don't go back to full exercise for about a week. Then a couple of good questions. Do you stop the heart? So in open heart surgery, the heart is stopped, and it's called bypass surgery for two reasons. Sometimes you bypass blockages, you get past them, but there's a bypass machine called a heart-lung machine, where you basically put tubes in, pull the blood out of the body, put oxygen into it outside the body, and put it back, and basically bypass the heart and the lungs. And you do stop the heart to do that. The procedures that I do when we're working on the heart's still moving. So we do have the motion of the heart to deal with. So it does make it a little more challenging. The open heart surgeons, they do need at times to stop the heart. Good question. What is the difference between cardioversion and defibrillation? So they are both electric shocks delivered almost the same way. Cardioversion is when it's planned and elective and it's a controlled rhythm. Defibrillation is when you do it urgently. And there's some subtle differences on how the energy is delivered in that sense. And then let's see, there's some more questions coming in. And how do people deal with pain during surgery? So during most of these procedures, patients are either given some sedative medications to make them sleepy. During catheterizations, you're partly awake. During certain types of ablations, you're partly awake, but sometimes we put people completely to sleep. That's what anesthesia is for. You can be put under general anesthesia. And then there's a question about age of patients. So these procedures are done across a full age range. Kids, it's usually a separate specialty and separate training instead of what I did, which is internal medicine, which is adult medicine. You go through pediatric training, and there's pediatric cardiology, pediatric electrophysiology, pediatric heart surgery. So it is a different training path, but a lot of the same procedures are done. Obviously, the equipment's a little smaller. And as far as the upper age ranges, depends on the procedure. You can have a pacemaker at any age. There's no age limitation. Ablations and some of our more complex procedures into the 80s, depending on the procedure.
once you get above 80, the risk for any procedure probably goes up, but up to about age 80, almost everything you heard people are eligible for. Let's see, I don't want to go too long here. And then I think I covered the kids, and yeah, they even operate on little tiny babies. I can say as someone who trained in adult medicine, I'm glad I'm not doing that, but they can even do open heart surgery on babies in their first year, or even first months. And it is a different pathway. Let me see if there's any other great question. Okay, here's a good one. How do you get a pacemaker in when they're in desperate need? So there are situations where, the need for pacing is urgent. The heart essentially has stopped beating or is beating incredibly slowly. And sometimes we put a temporary pacemaker in. We can get up through the groin again, the leg. We can get up into the heart from the leg very quickly, and we can put a little wire up there that will temporarily pace while we put in a permanent pacemaker. So in extreme emergencies, that's how we handle that. We put a temporary wire up, pace the heart, and take our time to do the rest. All right, there are more questions here, but I don't want to run people too far over, but I think we hit some of the best ones. Let me just see. And then here's another, let's see. And I guess just to follow up, one of the questions in there, how do you keep it alive when the heart stops? Well, depending on what you mean, when we purposely stop it, you actually can shock the heart back into rhythm. But most of the electric shocks, cardioversion defibrillation, we don't really stop the heart, you restart it. It's almost immediate. But depending on what the problem is that's causing the heart to slow down or stop, there's different techniques to get it going again. Okay, I think I'm just looking to see if there's anything we should address. We are about 10 minutes over. I think we should probably call it, but thank you everyone again, our participants, our panelists, our host, Dee Dee, our schools, Wender Weiss Foundation. Thank you to everyone again. Thank you so much. This has been great.
Have a great afternoon. Thanks, everyone.